Good morning, everyone. Today I'll be presenting an overview of gastritis, including its definition, major types, causes, clinical presentation, diagnosis, treatment, prevention, and follow-up. We'll also pay particular attention to H. pylori, or H. pyloric, because it is one of the most important causes of gastritis. By the end of this presentation, we should be able to recognize the major forms of gastritis, understand how they are diagnosed and treated, and identify important complications that require follow-up. Overall, early recognition and appropriate management can improve outcomes and help prevent complications. To begin, gastritis is inflammation of the gastric mucosa, which is the protective lining of the stomach. Histologically, it can be divided into acute and chronic forms. Acute gastritis is characterized mainly by infiltration of neutrophils, which are associated with acute inflammation. In contrast, chronic gastritis is characterized mainly by mononuclear inflammatory cells, especially lymphocytes and macrophages. Therefore, the important point is that acute and chronic gastritis are distinguished primarily by the type of inflammatory cells seen on histology. Gastritis is not a single disease. It can result from infectious, chemical, autoimmune, vascular, and stress-related causes. Now that we understand the basic classification, let's look at some of the major types of gastritis. Erosive gastritis occurs when the gastric mucosa is directly injured. Common causes include NSAIDs, alcohol, and other irritating substances. It may also be associated with vascular congestion, such as in portal hypertension or gastric antrovascular ectasia. In contrast, reflux gastritis results from prolonged exposure of the stomach to bile or pancreatic secretions that reflux backward from the duodenum. These substances chemically irritate the gastric mucosa and can produce chronic inflammation. Beside the erosive and reflux gastritis, there are several other important forms. Hemorrhagic or stress-related gastritis is commonly associated with severe physiologic stress, including hypovolemia, hypoxia, shock, major burns, trauma, or critical illness. These conditions reduce gastric mucosal perfusion and increase the risk of mucosal injury and bleeding. Infectious gastritis is most commonly associated with H. pylori, although other infectious agents can occasionally be involved. Finally, atrophic gastritis involves progressive loss of gastric glands and may occur in autoimmune disease. Autoimmune atrophic gastritis can lead to vitamin B12 deficiency and pernicious anemia and is also associated with an increased risk of gastric neoplasia. Having reviewed the major types, we can now move to the etiology and pathophysiology. Normally, the stomach is protected by a mucosal barrier that includes mucus, bicarbonate, epithelial cells, good blood flow, and prostaglandins. Gastritis develops when damaging factors overwhelm these protective mechanisms. For example, H. pylori causes chronic inflammation of the gastric mucosa. Alcohol can directly irritate and damage epithelial cells, while aspirin and other NSAIDs inhibit prostaglandin synthesis, reducing mucosal protection. Severe physiologic stress can decrease gastric blood flow, and autoimmune mechanisms can target gastric parietal cells. Therefore, the basic mechanism is an imbalance between harmful factors and the stomach's protective defenses. Once this mucosal injury develops, patients may present with a variety of symptoms. Common symptoms include burning or aching epigastric pain, upper abdominal discomfort, nausea, vomiting, decreased appetite, and sometimes unintentional weight loss. Patients may also report belching, abdominal bloating, early satiety, or a feeling of fullness after eating. In some cases, eating may worsen the discomfort. However, these symptoms are not specific to gastritis and may overlap with several other gastrointestinal disorders. Significant gastrointestinal bleeding is generally uncommon, but it may occur in erosive or hemorrhagic gastritis and can present with melena, hematemesis, or other evidence of blood loss. However, not every patient with gastritis presents with typical gastrointestinal symptoms.
In atrophic gastritis, vitamin B12 deficiency may produce neurologic manifestations such as tingling, numbness, sensory changes, weakness, or balance problems. Some patients may also be completely asymptomatic, and gastritis may only be identified during investigation for another problem. Because of this, taking a careful history is very important. We should ask about smoking, alcohol consumption, NSAID use, previous radiotherapy, gallbladder disease, autoimmune disorders, inflammatory bowel disease, vasculitis, and other associated conditions. A good history can often provide important clues to the underlying cause. After taking the history, the next step is the physical examination. In many patients, the physical examination may be normal or show only mild epigastric tenderness. However, the first priority is to assess the patient's vital signs, particularly if gastrointestinal bleeding or volume depletion is suspected. Hypotension, tachycardia, dizziness, or delayed capillary refill may suggest hemodynamic instability. Pallor may indicate anemia, and some patients may show physical signs associated with chronic alcohol use. Stool testing may occasionally reveal occult blood. Overall, physical findings can be subtle, so they must always be interpreted together with the patient's history and symptoms. Because the symptoms and physical findings are often nonspecific, we also need to consider the differential diagnosis. Functional dyspepsia can cause similar epigastric discomfort without visible structural disease. Peptic ulcer disease may produce more localized mucosal injury and can also cause bleeding. Viral gastroenteritis should be considered when nausea, vomiting, and diarrhea are prominent. More serious conditions, including gastric cancer, should be considered especially when alarm features are present. Other possible causes of upper abdominal pain include cholecystitis, pancreatitis, and pancreatic tumors. Therefore, age, symptom pattern, associated features, and alarm symptoms help guide further evaluation. Once the differential diagnosis has been considered, we can proceed to the initial diagnostic evaluation. Routine laboratory tests in uncomplicated gastritis may be normal. However, when bleeding or chronic blood loss is suspected, a complete blood count can help identify anemia, while ferritin can assess iron stores and detect iron deficiency. One of the most important investigations is testing for H. pylori. The stool antigen test detects active infection and has good diagnostic accuracy. It can be used both during the initial evaluation and later to confirm that eradication therapy has been successful. Another important non-invasive test is the urea breath test. This test detects urea's activity produced by H. pylori and is highly accurate for identifying active infection. In comparison, H. pylori serum IgG testing detects antibodies. Although serology is inexpensive and may indicate previous exposure, antibodies can remain positive for a long time after the infection has been eradicated. Therefore, a positive serologic result cannot reliably distinguish between active and past infection. Most importantly, serology should not be used to confirm eradication after treatment. For that purpose, stool antigen testing or the urea breath test is preferred. Moving on to pharmacologic treatment, several groups of medications may be used depending on the underlying cause and severity of symptoms. Antacids can provide rapid but temporary symptom relief by neutralizing gastric acid. H2-receptor antagonists, such as famotidine, reduce gastric acid secretion. Proton pump inhibitors, including omeprazole and esomeprazole, provide stronger and more sustained acid suppression and are commonly used when symptoms are more significant. Sucralfate forms a protective barrier over damaged mucosa and may help promote healing. Misoprostol, a prostaglandin analog, can help protect the gastric mucosa in selected patients, particularly when NSAID-related injury is a concern. Therefore, pharmacologic therapy aims to reduce acid, protect the mucosa, and address the underlying cause. However, when H. pylori infection is confirmed, eradication therapy becomes particularly important. A commonly recommended first-line approach for treatment-naive patients, especially when clarithromycin resistance is high or unknown, is 14-day bismuth quadruple therapy. This regimen includes a proton pump inhibitor, bismuth, tetracycline, and metronidazole. Using several medications together improves the likelihood of successful eradication and reduces the impact of antibiotic resistance. Adherence is essential because the regimen involves multiple daily doses. Patients should also be informed that bismuth can temporarily cause black discoloration of the stool or tongue, which is generally harmless but can be alarming if they are not warned beforehand.
If standard first-line therapy cannot be used or treatment fails, alternative and rescue regimens are available. These may include rifabutin-based triple therapy or vonoprazan-based treatment. Vonoprazan is a potassium-competitive acid blocker that provides potent acid suppression and may be combined with amoxicillin, with or without another antibiotic depending on the regimen. Clarithromycin-containing triple therapy should generally not be selected empirically unless clarithromycin susceptibility is known or local resistance patterns support its use. Therefore, treatment should be individualized based on previous antibiotic exposure, local resistance patterns, susceptibility results when available, previous treatment history, drug availability, and allergies. Despite appropriate treatment, H. pylori eradication may sometimes fail. In this situation, the next regimen should generally use a different antibiotic combination and take previous treatment into account. If optimized bismuth quadruple therapy has not previously been used, it may be an important rescue option. If it has already been used appropriately, other regimens such as rifabutin-based therapy may be considered. Levofloxacin-based therapy should be reserved for selected cases, ideally when susceptibility has been demonstrated, because resistance can significantly reduce its effectiveness. Probiotics may sometimes be used as adjunctive therapy to reduce gastrointestinal adverse effects, but they should not replace antibiotic eradication therapy because probiotics alone do not reliably eradicate H. pylori.
After treatment, follow-up is essential. Successful eradication of H. pylori should be confirmed rather than assumed from symptom improvement. Testing is generally performed at least 4 weeks after completion of antibiotic therapy, using a stool antigen test or urea breath test, while ensuring that interfering medications have been appropriately withheld. Repeat endoscopy may be considered when symptoms persist, when severe disease was present initially, or when there are specific endoscopic indications. Patients with advanced atrophic gastritis or other premalignant changes may require individualized long-term endoscopic surveillance because of their increased risk of progression to dysplasia or gastric cancer. Finally, lifestyle education and recognition of complications are important components of long-term management. Depending on individual symptoms, patients may benefit from limiting foods or drinks that worsen their discomfort, such as excessive caffeine, spicy foods, alcohol, carbonated drinks, or high-fat foods. Smoking cessation, limiting alcohol, avoiding unnecessary NSAIDs, and maintaining an appropriate diet should be encouraged. Potential complications of gastritis include gastrointestinal bleeding, gastric outlet obstruction, gastric intestinal metaplasia, gastric adenocarcinoma, and gastric neuroendocrine tumors associated with chronic autoimmune gastritis. In summary, gastritis is a broad group of conditions involving inflammation and injury of the gastric mucosa. H. pylori is one of the most important causes, but medications, alcohol, autoimmune disease, physiologic stress, and chemical injury can also contribute. Diagnosis depends on careful history, physical examination, appropriate testing, and endoscopy when indicated. Treatment focuses on eliminating the underlying cause, suppressing acid when needed, protecting the gastric mucosa, eradicating H. pylori, and preventing recurrence and complications. Finally, appropriate follow-up is essential to confirm eradication and monitor patients who are at increased risk for progression. Thank you for your attention.